Mr. Chairman, good afternoon, ladies and gentlemen. This is my great pleasure and honor to be invited for joining the 4th Asia Pacific Vascular Intervention course. This is my first time in India, in New Delhi. It's a lovely city, and I love to come back here again, and I'd like to invite you to come to visit our country also. This is the hospital that I come from, Sirirat Hospital. This is the first hospital of Thailand and also the largest hospital of Thailand, containing 2,500 beds. And we serve people all over the country also as a tertiary care. For endovascular service, we're working quite well among vascular surgeon, cardiac thoracic surgeon, vascular interventionist, cardiologist, neurosurgeon, and neurointerventionist. This is our team of vascular surgeon. We have 7 staff. Also, cardiac surgeon, Dr. Warawong, interventionist, Dr. Thanongchai, and cardiologist, Dr. Natchwood. We're working together quite well. That means we can do many things that are difficult case. Our topics that I would like to provide for you today is our experience in our hospital in the topics of peripheral artery embolism, peripheral atherosclerotic occlusive disease, carotid artery stenosis, AAA, thoracic aneurysm and aortic dissection, peripheral aneurysm, and vascular injury. For the first one of peripheral artery embolism, we have both treatment, open endovascular, embolectomy with or without intraoperative thrombolysis, and endovascular thrombolysis or mechanical thrombectomy device. This is the first vascular surgery that our training need to do that for embolectomy when the patient have the acute arterial occlusion of the extremity. Sometimes it's simple, sometimes it's not, particularly when the occlusion occur more than 24 hours. We need to do thrombolysis as well in the operative period. But right now, when the patient have the 2A ischemia, low extremity, that means there's no neurological deficit. We can use catheter-directed thrombolysis, and the results seem to be better than embolectomy when the patient have the embolism occur more than 24 hours. This is the machine that we inject the thrombolytic agent. For saddle embolism, it's doing quite well. When the patient has not serious ischemia, we can open the all extremity, artery of both extremity quite nicely. And also iliac artery embolism, and also proximal artery embolism. For success rate, we can compare with Stiley and Topaz that our series is comparable in terms of the amputation-free survival, 30 days, 6 months, and 1 year. And also mortality a little bit higher than Stiley. However, when we adjust the dose of the thrombolytic agent, we can improve our survival. For peripheral atherosclerotic occlusive disease, we also have endovascular treatment and open surgery, like arterial bypass, and endovascular treatment. We can use balloon angioplasty with or without endovascular stent. And however, when we have more complicated case, we can use hybrid procedure. This is the figure of our peripheral atherosclerotic occlusive disease in our hospital. It's increasing quite nicely, and we need to work harder and with more complicated cases. For endovascular work, it's increased more in a few years' time, but bypass still the same. Like a suprainguinal disease, in the past, we're doing aorto bifemoral. It's working quite well. However, when the patient has a compromised cardiopulmonary status, we need to do axial bifemoral. And if we see something like this very short segment occlusion, we can do the aortic kissing stent with less mortality and very favorable outcome. Or short segment of bilateral iliac endovascular stenosis, we can use bilateral iliac endovascular stent also. And immediately we can feel the pulse at the groin and down below to the foot. For inguinal peripheral arteriosclerotic disease, we have the extensive vascular bypass program to save patients' limb, particularly in diabetic patients that if you like to attend more in our country, we have what we call complex arterial bypass. We can bypass from anywhere from the body, like ascending aorta, descending aorta, abdominal aorta, down below to the ankle. And this one December of the iliac artery to posterior tibial artery by using vein in situ. And if you see the bad foot like this with infected toe and heel, when we doing bypass, we can obtain the healing foot nicely like this. However, when the patient has short segment of artery stenosis of infrainguinal lesion, we can use balloon angioplasty. If it's still recurrent or recurrent stenosis, we can use endovascular stent. And right now, we can use more aggressive endovascular treatment with the long occlusion by using endovascular stent after angioplasty with the long stent. Furthermore, we can use for intraposteal lesion only balloon angioplasty, but sometimes we use short stent for the short lesion. We cannot use long stent with the long lesion. That's why bypass still coming up, still useful in the infraposteal lesion. And balloon angioplasty, we start using drug-eluting balloon right now. Sometimes we need to use hybrid procedure like this. We're doing the stent at the right iliac artery and then bypass from right femoral artery down below to left proximal artery, and it's functioning quite well. You can see the proximal artery, posterior tibial artery, and come down to the ankle and the foot, and the ulcer is healing very nicely. And also, we use aortic stent by a kissing stent and doing left femoral proximal bypass successfully. Sometimes we have to face with acute arterial thrombosis. We need to use thrombolysis agent first, and then angiography. When we see the distal runoff, we can use balloon angioplasty and endovascular stent also, and we can open the whole leg and avoid the major amputation. Sometimes endovascular treatment is useful in surveillance program and keep the bypass more successful. On the left-hand side, we perform the aorto right proximal bypass and left anterior bypass extensively. 2 years later, patient has left limb graft occlusion. We can open the left limb nicely with catheter-directed thrombolysis and endovascular stent at the distal anastomosis successfully. So the result is just short-term, it's not mid-term or long-term, because the patients refer to our hospital all over the country. So it's quite difficult to follow with the long-term outcome. However, we got quite a good number of results of arterial bypass. The number of endovascular treatment is slightly low because we accumulate the type C and D together. Not if this patient with task A or task B, the result is more than 90% also, and mortality is better. For carotid artery stenosis, we also have both treatment, endovascular stent and atherectomy. This is the example of the case with symptomatic artery stenosis. We got the referred case from neurologist who had TIA, amaurosis Fujac, or contralateral hemiplegia. So we have the technique of an atherectomy with the routine shunt and under general anesthesia, and we remove the plaque down to external elastic lamina. That means smooth muscle cell layer is gone. So the long-term pattern is quite good. And also you can see on the right-hand side at the bottom, we can use a vein patch to prevent long-term stenosis, and we got quite a good outcome. This is the CTA after pre and post-operative endarterectomy. Endovascular we perform, but it's not doing well. Probably we need to learn more, and at that time we also use cerebral protective device. However, the result is not so good. So we stopped for a while for a few years. So we go ahead completely with endarterectomy surgery with a good outcome. Major stroke is only 2.4 and the same mortality. But the stroke is higher in endovascular treatment. For AAA in our hospital, we do both in elective and rupture, and also unstable vital signs. Endovascular and open repair still the treatment in our hospital. Like this, so for AAA electively, we use steel graft and bifurcated graft. We can also perform bifurcated endovascular graft and aortounilateral graft. Also in rupture, we have done about 18 cases and doing well with aortounilateral or tube graft like this. And we perform only 3 cases of bifurcated graft, but it's not doing well as aortounilateral graft, because this graft is working wonderfully in emergency situation, particularly when the patient is unstable vital signs. For the number of open repair and EVA, we have the increased number since last year, and all the result of open repair and EVA. We have the result of elective. It's in EVA is slightly better than open repair, and nearly the same in rupture. So I think in the future we may make a better outcome in EVA, what we think, because it has less invasive, less hospital stay and ICU stay, and less blood transfusion. So the problem of the endovascular for AAA in our country, we have suprarenal extension and short neck of AAA, and severe aneurysmal angulation more than 60 degrees, and small iliac artery because our population is quite small, and severe toxicity of iliac artery, stenotic and calcified iliac artery, and also infected AAA. We solved the problem of suprarenal extension by doing 5 cases of fiduciary graft, and it's doing well, all of them. Also, sometimes we use chimney graft for generate SMA and renal artery. For the rupture of infected AAA, we have the for the EVA infected AAA, we have non-rupture 11 cases, rupture 4, and aortoenteric fistula 3. Total is 18, but we have 1 case mortality is died from rupture AAA. For infected AAA, this is the common procedure in our population. Usually come with fever, abdominal pain, and circular aneurysm. And most common occurrence is salmonella infection. We use tube graft. It's working quite well, but it's just short term. We need to follow at a long-term outcome. And sometimes we need to take the graft out when we face with aortoenteric fistula. This is our strategy also when we face patients of rupture AAA and unstable vital signs. We use intra-aortic balloon occlusion. That means we can cannulate percutaneously or cut down through the femoral artery, and then we can pass the catheter with guide wire and insert the balloon to improve the systemic blood pressure, and then we can go ahead either EVA or open repair. Before and after intra-aortic balloon occlusion, we can compare the protein is reduced enormously from 57% to 15%. About thoracic AAA and aortic aneurysm and aortic dissection, I got the complimentary from my colleague, Dr. Warawong, and he also performed endovascular and open repair. This is the picture of the diagram of the number of open repair and TIVA from the year 2005 and 2011. And the number of endovascular repair for thoracic aortic disease, mainly thoracic aneurysm is the main indication, followed by acute and chronic dissection, traumatic aneurysm, microtic aneurysm, and penetrating aortic ulcer. For the outcome, doing well with traumatic and penetrating aortic ulcer, but not doing well with microtic aneurysm. For dissection, some patients not survive due to the multiple organ failure. This is the picture of TIVA with carotid to subclavian bypass. He is doing carotid to carotid bypass with TIVA, and also aortocarotid bypass with TIVA is aortic arch aneurysm, and TIVA for aortic dissection. Apart from that, we need to face with peripheral aneurysm. We are also doing open graft replacement or ligation or endovascular stent graft. Like this, we have carotid aneurysm with the aneurysm extension to base of skull. It's not possible to do open repair. So we use endovascular stent graft with very good successful outcome. With stent graft, patient doing well until 5 years, and now she's doing very well without neurological deficit and no scar. This is a picture of endovascular stent graft. Sometimes we have sacral aneurysm of AAA. We're doing endovascular stent graft with two graft. For the carotid blowout, with breathing and patients have difficulty of breathing, we need to maintain airway, and we cannot do open surgery if a patient may die from the breathing. And then we start cannulation through the right groin upward and blow the balloon at the carotid artery and do an angiogram first. And then on the left groin, we prepare for subsequent to do vein graft for if the repair is possible with vein graft. So you can see the balloon is occluded quite well. You see no serious bleeding. But the carotid artery itself is friable and infected, so we cannot do repair with vein graft. So we only doing the ligation only. Luckily, that patient have no neurological deficit and he survived. That is infected carotid aneurysm. For my last slide, it's a femoral aneurysm infected due to, unfortunately, it's a heroin addiction with HIV infection, with hepatitis C infection. So it's the swelling of the both groin, and nobody want to fix it and refer to us. Then we do cut down at the distal posterior femoral artery and passing guide wire and put the stent graft on both sides and doing quite well. And for long-term outcome, it's still doing well. So stent graft is still possible in this area, and we can avoid the contamination of infection from HIV and hepatitis. Accidental arterial catheterization. This is the double bank catheterization for hemodialysis, and it accidentally generate into innominate artery. If we remove the catheter, it would be dangerous. So we fix it with the endovascular stent graft successfully, and patients doing well. So I would like to make a summary that endovascular treatment is highly benefit in selected peripheral arterial disease. Special criteria of selection should be based on the evidence in both short-term and long-term outcome. Application of endovascular treatment in surgical practice may vary in different situations of each country. However, open surgery is still necessary in the advanced stage of disease and provide effective long-term outcome in reasonable general status. Cooperation between interventionist surgeons could obtain the high success rate of endovascular treatment in complicated vascular problems. And this is our team. And on the right bottom is Dr. Rome, my colleague, who will present to you about thoracic aneurysm, infected thoracic aneurysm by endovascular treatment. Thank you very much for your attention.
Thank you very much for this very interesting lecture. I don't think we have question, no time. Dr. Khanna?
Thank you very much, Dr. Pramukh. Now, we are going to ask Dr. Professor Emin Khanna, Dr. Dietrich, and Dr. Collins, Dr. Michelle Henry, to give this the trophy and plaque to Dr. Mutiranga. It reads at Gopi Devi Khanna Oration 2002 for the year 2012 has been conferred to Dr. Pramukh Mutirangura from Thailand for the topic endovascular therapy in peripheral vascular disease at the 4th Asia Pacific Vascular Interventional Course held at New Delhi, India from 8th to 10th of June 2012 for his prominent contribution in the field. Asia Pacific Vascular Society wishes him many more years of good health and academic excellence. Dated 8th of June 2012.
Ladies and gentlemen, may I invite our members of the expert panel, Professor Emin Khanna, Dr. Chai Collins, Dr. Dietrich, and Dr. Henry. Gopi Devi Oration for the year 2012 has now been conferred on Dr. Pramukh Mutirangura. Many congratulations, Dr. Mutirangura. Thank